Welcome back to another episode of Oncology for the Inquisitive Mind, featuring none other than your co-host, Dr. Josh Hurwitz and Dr. Michael Fernando. Michael, I have a grin because I was right, but it's so good to see your beautiful brown eyes. How are you today?
Yes, in case you haven't noticed, we are trying a video edition. We've had a number of lovely listeners reach out to us and say they prefer a more visual content, an emphasis on the visual in audio visual. So we're trying that. We're doing better this time than our last take, Josh, where you didn't know what shade of color or what color my eyes were.
They're a beautiful brown, and AI will never be able to replace that, Michael.
It's a long story. Josh, why don't you just talk about what our subject is today, which of course is heavily pretreated HER2-positive breast cancer.
That's it, Michael. You have hit the nail on the head, but we're going to go back to basics. I'll give a bit of a background. Michael will talk about his trial in depth, and I'll finish it up with another interesting conversation. So breast cancer, I love this stat. It's a terrible stat, but it is the most common cancer diagnosed worldwide. That represents 1 in 8 women will be impacted in their lifetime in the Western world. Estrogen was originally found as a driver in the 1970s by Elwood Jensen. Michael loves history, like regular history. I love oncological history. And it represented a milestone in understanding the biology of this cancer. HER2 then was discovered in the 80s and 90s by Dennis Salmon and German biochemist Axel Ulrich. So what is HER2?
Excellent pronunciation, by the way, there, Josh.
Thank you. My grandmother would be very proud. So HER2 is a 1,255 amino acid glycoprotein belonging to a transmembrane tyrosine kinase, and it's used in coding proto-oncogenes and is located on the long arm of chromosome 17. So overexpression of this particular receptor causes problems, as expected. So it increases heterodimer formation, reduces endocytosis, and in English, causes an upregulation of downstream pathways. This leads to increased cellular growth, inhibition of pro-apoptotic factors in the tumor cell, making it a more biologically aggressive entity. When first identified in the mid-80s, HER2 amplification was found to represent a 45-fold increase in receptor cell density in the cell membrane, with an increased signaling cascade leading to all the problems that I mentioned. And you're like, does this matter, Josh? Why do I care? Michael, do you care?
Well, I'm sure you're going to tell me why.
You do care. That's the answer I was looking for. So originally in the 80s, you had surgery, you might have had chemotherapy, no other treatment. But what they found is that with HER2 amplification, it caused a reduction in progression-free survival and overall survival in these patients. And, one of those things that's nice as a trainee or as a junior specialist to be able to quote such interesting facts. Or sad facts, really. But progression-free survival after diagnosis of distant disease was as low as 4.6 months at that time, and overall survival being 20 months. That is the same as pancreatic cancer, to put it out there. And, the HER2 diagnosis became a game changer and continues to be a real game changer, not only in breast cancer and other cancers. Enter right stage. Enter stage right. Man, I had one line not to mess up, and here we are.
Yep.
Trastuzumab. So trastuzumab was the first monoclonal antibody against HER2, and it was a 20-year milestone, and recently from it being discovered, and it has revolutionized this cancer. So the way it works, it blocks the extracellular domain of HER2. It prevents receptor dimerization. And there's lots of theories as to why it stops reproduction, but they don't really know. There's lots and lots of theories.
It works. No one's going to ask why.
Yeah, I've got a list of things. If you want, send me an email and I can send you what I wrote. More recent developments. There's been more HER2 treatments, which is, my favorite topic, and Michael listens to me yabber on about ADCs, but you've got pertuzumab, which causes dimerization inhibition, antibody drug conjugates like trastuzumab emtansine, trastuzumab deruxtecan, and Dato-DXd, and lots of other really interesting sort of ADCs are coming out. So The other thing to talk about is what we consider HER2 enriched. So, usually defined as an immunohistochemistry of 3 plus and confirmed by a secondary test called in situ hybridization. So, traditionally, ISH negative or, HER2 negative was considered IHC2 plus or ISH negative. These days, that is actually changing with HER2 low, HER2 ultra low, and look at Destiny Breast 06 and Destiny Breast 04. And if you're interested, check out our ASCO episode, a couple of episodes back, where we talked about Destiny Breast 06, and it is your destiny. How am I doing, Michael?
I'm so glad that we have the video now because our audience can actually see when I facepalm.
That's it. So to confuse you, Michael is talking about something completely or slightly left of field, tucatinib. I won't talk about what tucatinib is, but the current landscape for metastatic breast cancer is as follows. Trastuzumab plus pertuzumab and chemotherapy based on the Cleopatra and Peruse study. So check that out. We'll leave a link in our description at the bottom of the screen. I've never done this before. I don't think we're ever going to publish this episode online, but we might. Second line is now trastuzumab deruxtecan, and third line is tucatinib, but I won't spoil that for Michael. There are heaps of issues still in this space, like all solid oncology spaces, but it predominantly comes down to resistance. Michael, I'm done. I did a breakdown in 6 minutes. How was that?
That was pretty good. I've got to give you credit, Josh. That was pretty good. Although it is interesting that you left out what may have been a forgotten anti-HER2 treatment, which is TDM1.
Oh, yeah. TDM1. Oh, yeah, it's in my notes. Look, you've got I did mention trastuzumab and tansine in passing, but it's been asserted by TDXD, and so it's actually an interesting conversation point later line after TDXD. There's no studies that look at TDXD, then TDM1.
We don't know if there's resistance mechanisms, but anyway, we are getting, as is our prerogative, we are getting off topic. So thank you for that introduction, Josh. You set me up quite well because a lot of what you were talking about actually leads very nicely into what I'm talking about, which is HER2 climb, which, as you mentioned, is the study of tucatinib. And you mentioned how the massive advances in treatment of HER2-positive metastatic breast cancer have greatly improved outcomes for patients with trastuzumab and then TDM1, now TDXD, which, is just the darling, the Nobel Prize winner of oncology, as it were. But there is a dark side to that fact, and that is that despite increased survival, brain metastases are developing in more patients because they're lasting longer, the disease is getting more resistant, and therefore it's got more time to sneak its way into the CNS. So currently, or at the time that HER2 Climb was published, they estimated that up to half of patients might develop brain metastases in their lifetime, in their disease journey. And we don't have to tell anyone how morbid, how disabling brain metastases can be. At the time, this obviously predates all of the sea change brought along by TDXD, but after progression on TDM1, which was the second line treatment of choice at the time, there was no consensus on the standard of care. Tucatinib is an oral TKI, and Josh will be able to tell you that we love an oral TKI, an oral treatment on this show, that is highly selective for the kinase domain of HER2, which the authors suggest might actually change the toxicity. HER2 Climb was a study that examined the combination of tucatinib, trastuzumab, and capecitabine in this heavily pretreated population, basically trying to give people another line that they could fall back on that had strong evidence. So this was a randomized, double-blind, placebo-controlled trial that compared tucatinib, trastuzumab, and capecitabine with a placebo plus trastuzumab plus capecitabine. And there's an interesting talk or an interesting point here before we even get off the ground, which is the re-challenge of trastuzumab. It is interesting that these patients had to have received trastuzumab, pertuzumab, and TDM1. That's a key inclusion criteria. And the re-challenging of trastuzumab is interesting. It is something that I have seen in clinical practice, but I don't think there was ever any evidence for it, this combination of trastuzumab plus capecitabine. Josh, have you got any pearls of wisdom on that point?
My practice experience has been we never really re-challenge with anything. I think That's more so due to the Australian landscape of funding,
Hmm.
because there's always this question about adding other drugs to help with, the resistant mechanisms, and it's heterogeneous, so you're never going to know that all of the cancer cells and all of the deposits are going to be chemo or treatment resistant. So it's
Hmm.
a interesting point.
And if we're extrapolating from our approach to hormone receptor positive breast cancer, if you are one of these people who unfortunately has an early relapse, then what I've heard people say, like Belinda Yo, who's been on the show previously, she always said that if you've got someone who relapses early despite appropriate anti-endocrine therapy, then the cancer probably wasn't driven by the endocrine receptors anyway, or you've selected for the cancer cells that are behaving much more in a triple negative fashion. I wonder if that's the same here, where if you've just blasted the cancer with anti-HER2 treatment, eventually it starts to lose its responsiveness to blocking the HER2 overexpression. And so adding capecitabine, sort of from a triple negative perspective, might help that. Moving on, Josh is staring blankly into space. Don't worry,
No,
everyone.
I,
He has a
I
clue.
was musing of your wise words of wisdom, Michael, but I agree. And that's also why you re-biopsy when someone progresses, because you're not going to really know what is happening to the cancer unless you biopsy. And I appreciate people don't want to biopsy every time you change treatment, but maybe ctDNA will be that answer
All
eventually.
those vacuum assisted biopsies that were a couple of ASCOs ago.
Yeah, a couple of ASCOs. What a
Anyway,
whirlwind.
What a sentence. So we talked about key inclusion criteria being previous treatment with basically every anti-HER2 agent that we had at the time. Other key inclusion criteria were patients had to be greater than 18 years old. They had to be HER2 positive on the basis of immunohistochemistry-ISH or FISH, which is fluoro in situ hybridization, which is just another way of confirming the HER2 status. They had to have an ECOG performance status of 0 to 1, and critically, patients with brain metastases were allowed. However, leptomeningeal disease was an exclusion criteria. So that's something important. It's good that they're including patients with brain mets because, as we've said before, HER2 positive breast cancer makes a beeline for the CNS, and that was a major cause of mortality before the onset of trastuzumab, or before the discovery of trastuzumab. 612 patients were enrolled, and they were randomized 2 to 1 to the tucatinib versus placebo trial. And we always say when you randomize something 2 to 1, you have to be pretty confident that the experimental arm is going to be better than the control arm. The primary endpoint was, interestingly, the progression-free survival in the first 480 patients randomized. I'm not really sure. I think it was for statistical reasons, but I'm not sure why they cut off at 480 but then continued enrollment. It might be that they had lots of takers and they just wanted to keep enrolling.
Who knows? One day we will have a statistician on this show to explain all of these weird and interesting choices that they make. Once someone told me to figure out a power, you pluck a number and then work backwards. That all seems very fascinating to me.
Yeah, absolutely. That's something that you should look forward to coming soon, maybe on Oncology for the
To a
Inquisitive
theater
Mind.
near you this
A
summer.
theater near you this summer. The latest blockbuster from Steven Spielberg. The secondary endpoints were overall survival. These are in all patients. The progression-free survival in patients with brain metastases at baseline, as well as in the total population, the confirmed objective response rate, and the safety profile. So let's try something a little bit different. I am going to share
Bear
a
with us.
screen.
Oh, hello. Look at this. You
How about that?
brilliant man.
So this is, again, and when we show up these are directly taken from the article. All rights and copyright go to the original authors and to the New England Journal of Medicine. Now that we've got that out of the way, we can say that the demographics were broadly similar. As you can see, the demographic data is split into the primary endpoint analysis population, that's the first 480, compared to the total population, which is 612. You will note that there are slight differences in patients' age. So there were more elderly people greater than or equal to 65 years old in the tucatinib. Patients in the experimental arm were more commonly Asian or Black in ethnicity, and they were less likely, and we're talking a few percentage points here, but it's worth pointing out, they were less likely to be ER/PR positive and less likely to have an ECOG performance status of 1. And we're back. How about that? The median progression-free survival was 7.8 compared to 5.6 months. And if you thought that the first thing I shared was good, you ain't seen nothing yet. So we can actually show Kaplan-Meier curves, and I am loving this right now. So this is the median progression-free survival based on the first 480 patients. And as you can see, hazard ratio was 0.54, and this was statistically significant. The benefit was consistent across all subgroups, although you will note that the more elderly cohort just here did cross the line of equivalence, but small numbers there. The median overall survival was 21.9 compared to 17.4 months with a hazard ratio of 0.66, again, statistically significant. The 2-year overall survival rate was 44.9 compared to 26.6%. And you can see again the benefit was consistent across most subgroups. Now, this is the progression-free survival estimates for patients with brain metastases. The progression-free survival in this group was 7.6 compared to 5.4 months with a hazard ratio of 0.48. Again, statistically significant. And what I like about this, Josh, is that they are actually giving p-values to secondary endpoints, and that's not something that we see. So we can say definitively that tucatinib in combination with trastuzumab and capecitabine is better than placebo, and we can say that's statistically rather than just numerically significant. So in terms of safety, now, interestingly, the rates of adverse events leading to discontinuation, this is something that we talk about a lot in terms of really giving a proper sense of how the treatment impacts patients and how difficult it is to provide. The rates of discontinuation were very low, 5.7 compared to 3% in tucatinib versus placebo alone. And I think I do have a summary of this is making our job very easy, of the toxicity. Here we are. So as you can see, the most common toxicities associated with tucatinib were diarrhea, PPE, and nausea. But you can probably see as well that the rates of certainly grade 3 diarrhea, PPE, and nausea were similar across the two groups. Numerically, there was greater rates of diarrhea, PPE, and nausea, greater rates of toxicity as a whole with tucatinib, but you can tell that there is an underlying constant, and in this case, that's probably the capecitabine. So you can probably say that the toxicity here is mostly due to capecitabine, but there's obviously an additional toxicity with the tucatinib. I will also note that there was a significantly higher rate of LFT derangement in the tucatinib arm compared to the control arm. That's something that you should watch. So if you're starting a patient on tucatinib, make sure that you monitor their LFTs. So wrapping this up, there is a clear sequence of lines of treatment for patients with HER2-positive metastatic breast cancer. I've written in my notes here, we've got the Cleopatra regimen, THP, we've got TDXD. You could argue for TDM1 after TDXD, but I'm not sure where we are in terms of regulatory things. And then you've got this regimen, tucatinib, cape, and trastuzumab. Good for brain penetrance because the PFS benefit was maintained regardless of whether a patient had brain mets or not. Good from a toxicity perspective, probably tolerable, manageable, and obviously you've always got your dose adjustments. So it's a good option, Josh. That's really all I have to say.
It's nice that's just all you have to say, Michael, because
that's the final word.
It's an amazing final word. I'm like, you breeze through that. I should start because I know we have a time limit on this. So I don't have many questions, but it's an interesting study. I think tucatinib's also used for intracranially as a rule. People seem to prefer it, although because there is data on TDXD, but it wasn't driven for that particular endpoint.
Yeah, I think tucatinib's main selling point was its CNS penetrance.
Yeah.
And so if you do have a patient with CNS Mets, particularly if they're pre-treated, but that's an added benefit you'll probably get from tucatinib.
That's it. So I'm going to jump across to a slightly older trial, but I think it's worthwhile chatting about because it is a potential option for patients who are seeking later lines of therapy. So this is abemaciclib plus trastuzumab with or without fulvestrant versus trastuzumab plus standard of care chemotherapy in women that are hormone receptor positive, HER2 positive advanced breast cancer. It was a randomized open label phase 2 trial. So the background is CDK4/6 inhibitors that are used for estrogen receptor positive breast cancers. They haven't really been proven in the HER2 positive space, but the question was, what happens if you combine these drugs? Can you actually do something in later lines of therapy? There was a phase 1 study, and that showed some promising results with a partial response in about 36% of patients. So that's the background. So this study was done in 75 hospitals in 14 countries. Inclusion criteria, as you expect, important things to note: prior exposure to at least 2 lines of HER2 targeted therapy, either in combination with chemotherapy or endocrine therapy or as a single agent, was a must. Previous TDM1 and taxane exposure was required. Exclusion if they had visceral crisis, untreated CNS disease, really to be expected. So you randomize 1:1:1 to these 3 arms, either being abemaciclib, trastuzumab, and fulvestrant, arm A, or abemaciclib and trastuzumab, arm B, or chemotherapy and trastuzumab, arm C. The way I remember it, chemotherapy-free regimens in A and B, and you're giving chemotherapy in regimen C. So
C for chemo.
C for chemo. Brilliant. See, not just good looking.
And A for abemaciclib.
The primary endpoint was investigator-assessed PFS, and secondary endpoint was overall survival, objective response rate, duration of response, patients who had clinical benefit after certain periods of time. So 225 people were enrolled, about 75 patients in each group. The demographics were relatively well balanced. Of note, about 50% of all 3 arms had greater than 3 lines of therapy, and between 2 to 3 was about 44 to 50 something percent. Couple percentage points different. So most patients had endocrine therapy for metastatic disease, tamoxifen, aromatase inhibitor, and trastuzumab. Pretty much everyone had, and half of the patients had pertuzumab, and we'll talk about that point a little bit later. So stay tuned. Number of treatment cycles in Group A was 10, Group B was 8, Group C was 8, and the results were interesting. I think that's something to really say. And when we talk about the primary endpoint, the median follow-up was 19 months. The median progression-free survival was 8.3 months in Group A versus 5.7 months in Group C, with a hazard ratio of 0.67. Interestingly, eked out past that statistical p-value at 0.051, but it was significant when they used a pre-specified two-sided alpha of 0.2. Don't really know why, Michael. I don't know if you can
statistical wizardry. I think we really need to get someone who knows what they're talking about.
We will. And then the median progression-free survival in Group B was 5.7 months again, and not statistically different versus Group C. So they did Group B versus Group C. So they did a lot of post-hoc analysis with this, including blinded independent clinical review, and there was not really different. Group A was 7.1 months, Group C was 6.9 months, with a hazard rate of 0.883. So still you see that little bit different. There was about 16% that had brain mets while on the study, but not enough to make any statistical conclusions. I said it was interesting, but I feel I'm just saying there's not a lot, but there are questions that it raises and some interesting points. So duration of response, 12.5 months in Group A, 9.5 months in Group B, and Group C was not reached, which is interesting. Time to confirmed response was 2.8 in Group A, 4.2 in Group B, and 1.6, which is the chemo arm, in Group C. You saw a partial response in 32% of Arm A and maybe 14% in Arm B and Arm C, and stable disease in 46% versus 61 versus 53%. I'll see if I can share that. Well, hello. Michael's far more technologically savvy than me. There we go. Oh, look at that. It's going up and down,
Well
up and
done.
down. But as you can see, stable disease, 46 versus 48. 46 versus 61 versus 53%. And then you've got the overall response of 33% versus 14% versus 14%. So again, you're seeing arm A is getting better overall responses, I think, as a general summary. What is interesting, though, is the overall survival. So the median follow-up with this treatment paradigm was 52.9 months. The median overall survival was 31.1 months in arm A versus 29 months in arm B and 20 months in arm C. So arm A versus arm C had a hazard ratio of 0.71, but again, not statistically significant, just crossing that confidence interval. And arm B versus arm C again was not statistically significant, but numerically we did see a better outcome in the abemaciclib, the trastuzumab, and the fulvestrant. But the question is it enough? They didn't do an arm A versus arm B comparison, so that makes it really, really hard. Safety was relatively similar, and when you break down the groups, arm A, the most common side effects was pyrexia, diarrhea, UTI, and kidney infection. Group B was diarrhea and pneumonia, and group C was neutropenia. And of course, neutropenia was the biggest one, really, in all of them, based on abemaciclib and chemotherapy, as you would expect. So what are the discussion points? So it shows that numerically this combination is beneficial. Objective response rate was better in the intention to treat, and it's better than a lot of other trials when you look at sort of later line therapies. So Monarch showed that there was better progression-free survival and a high objective response rate while versus standard of care chemotherapy and trastuzumab, which is really its aim in this particular case. We know that endocrine therapy alone in HER2-positive cancers, not particularly beneficial. I think we can say that. Happy to be corrected from your part. But again, there was limitations to the study. It did not isolate the role of fulvestrant, really. Fulvestrant and trastuzumab, that would have required another arm, and it was not assessed for sort of intracranial disease. So it is an interesting conversation point. I think, what are your thoughts on this trial, Mike? I'd love to hear it.
It's tricky. I guess that the main thing, and forgive me if you mentioned this, but how many patients were ER/PR positive as well?
I don't know if I mentioned that. That is a really, really good question. I suspect they should have all been, because that was
you would suspect so.
I mean, again, it would be in the protocol, but the thing is, it was hormone receptor positive, HER2 positive cohort.
HER2 positive, yeah. So it comes back to what we were talking about before with disease drivers. And you see this all the time. The reason that we prioritize the chemotherapy, the anti-HER2 therapy, and, if they can get a bit of an anastrozole or letrozole, that's fine. But the reason we prioritize the first two is that is probably what's going to be driving the cancer growth.
Yeah.
And so it makes sense that as long as you have a trastuzumab in there, or element of trastuzumab in there, they're going to have some benefit. I thought the time to response was interesting because, again,
I agree.
If you've got metastatic disease, and I know they excluded people with visceral crises, which is very reasonable for a trial, then if you've got a high burden of metastatic disease, you're going to want to give them something that works quickly.
Mm-hmm.
So I'm not really sure that this would change practice, if that makes sense. I think that if you have someone who's triple positive, you're still going to give THP, but maybe you could add on an anastrozole or letrozole or an AI on top of that.
Maybe. I mean, this is third line, though. So that's the thing to remember. It is a late line treatment option where, I mean, I don't like what they said for overall response, because they excluded stable disease. I mean, I'd probably include stable disease in my overall response, because you're still
I think
controlling.
that's like that's a separate thing. That's like disease control rate.
Yeah, that's it. So it's how you define things. But stable disease was quite high in Group B and Group C. And I think what it does show, though, is that you do get benefit with abemaciclib to trastuzumab. I think it does show that, even if overall survival A versus B was very similar, but versus C, the numerical 11 months, I think, is something to really think about.
Yeah.
And if you can get it in your country, and I don't know if it's, I don't think it's approved here.
It's most definitely not for this indication.
But it raises questions because a lot of these people had previous trastuzumab, and we're giving trastuzumab again, and they're still responding.
Comes back to what we were saying with HER2 Climb as well. Are there additions that we can make to overcome resistance to anti-HER2 therapy?
That's it. So I hope you guys enjoyed this. We're probably going to stick this online. I don't know. I'll speak to Michael afterwards once we've kind of reviewed out what our faces look like. But feel free to leave a comment.
We need to make sure that we're not making stupid faces because we do that. We've done that a lot the last couple of years.
That's it. Mostly me at Michael. But join us next week as we have something else really interesting to talk to you about. Right, Michael?
Yeah, we're going to talk about lung cancer. I know we've spent a lot of time on lung cancer, but, I was reading an update of Empower 010 yesterday in my spare time because, I'm just such a
in front of the fire
dude.
with your hound and, your
Yes, my
reindeer
pipe.
mounted behind the fireplace.
Yes, all of that. So I was reading Empower 010 because I'd seen a patient who was receiving the regimen for adjuvant immunotherapy, and I was thinking it would be good to compare that with the neoadjuvant study, which is Checkmate 816. So it'll be an interesting discussion. We'll go through that and join us next week. Maybe video, maybe not. We don't know. We like to keep it a bit loosey-goosey, but regardless, as regular as your early morning breakfast, we will be here next week with more oncology facts.
Yeah, we're Weet-Bix kids. See you next week.
See you next week.